fat. Coming to dietary management, dietary restriction of fat intake to 10 to 15% of total daily calories with formula feeds is better, and adding supplementation with medium chain triglyceride, which are metabolized through chylomicron independent pathway. So better to start with MCT oils, and supplementation of fat soluble vitamins is necessary, but administration of fish oils may be beneficial, but in pediatric patient this is lack of confirmation. And intake of high doses of omega-3 fatty acids like eicosapentaenoic acid or docosahexaenoic acid also inhibits the VLDL production, reduces the chylomicron size, and promotes the chylomicron plasma clearance. Here one study showed who are treated severe hypertriglyceridemia with strict diet which is rich in omega-3 fatty acids and medium chain triglyceride. They described the use of these two along with strict diet as a therapeutic concept to reduce the plasma triglyceride levels. Effectively, they did. Coming to insulin role, intravenous insulin is a safe and effective for acute treatment for hypertriglyceridemia in infants, because insulin inhibits the LPL, which further leads to triglyceride to be hydrolysis into free fatty acids. But insulin role is only in the LPL deficiency babies, not in other enzyme deficiencies. Heparin also stimulates the release of endothelial LPL into the circulation, so increases the LPL activity, which is rapid hydrolysis of triglycerides into free fatty acids, but its role in very limited role in pediatric patients, because the risk of hemorrhage into the pancreas if under pancreatic necrosis is there is very high. Coming to plasmapheresis and exchange transfusion, both are very effective, because this one rapid direct removal of the lipoprotein particles decreases plasma viscosity. And the use of plasmapheresis is very limited due to the limited availability and technical difficulty in infant. So instead of that, whole blood exchange transfusion may be considered when the plasmapheresis is not feasible. And excellent response has been reported in a newborn with severe hypertriglyceridemia, which is done in 2018. They showed that they concluded that exchange transfusion appears to be a safe procedure and one of the alternative procedures for plasmapheresis to prevent the acute pancreatitis in young children. Coming to medical management, according to Nelson 21st edition, no medical treatment is recommended in infants, not either niacin, fibrates or statins. Although some studies shows fenofibrate may be indicated in child for more than 3-month-old age group. And recently one study did from 2021 pediatric endocrinology book, they suggested gemfibrocil for newborns at a dose of 15 to 20 mg per kg per dose BD before feed. Mechanism, it acts via the peroxisomal PPAR alpha enzyme, which leads to stimulate the beta oxidation of the free fatty acids, increases the LPL synthesis, and inhibits the lipolysis and receptor mediated clearance, which leads to VLDL clearance. All these things leads to decrease the synthesis of triglycerides and decreased level of VLDL, and one good thing, it increases the HDL levels. But this indication is limited. It had some side effects, especially GI intolerance is the most common side effect of gemfibrocil in form of nausea, anorexia, gastric pain. We can try to reduce the dose till 5 mg per kg per dose. If baby is not tolerating, better to take it out and go with alternate method. And for seeing response to treatment, it is assumed that serum triglyceride is the useful surrogate marker for the assessing the response of treatment, and it also predicts the risk of pancreatitis. Newer modalities, Glybera, one is LPL gene replacement therapy via adenosine associated virus type 1 gene, but in pediatric population not yet justified. One more is antisense oligonucleotides, which also inhibits the LPL mediated hydrolysis, still under trial. In the last 3-year period, we got total 4 newborns in ICH, which is from in 2018, we got one term gestation male baby who presented us at 21 day of life with non-specific symptoms. We noticed lipemic serum and we sent triglyceride levels, which is showing 43,600 milligram per deciliter. Lack of that genetic report is not sent, and treatment given exchange transfusion we did. Immediately after exchange transfusion, triglyceride levels are dramatically decreased to 680 milligram per deciliter. 2 more cases which are presented with non-specific features only, but triglyceride levels are around 7,000 with LPL gene mutation. We tried strict diet therapy with MCT oil supplementation. On follow-up, triglyceride levels are within normal limits. And last cases, which is I presented now, which is presented with GP1 HBP1 gene mutation. We started on gemfibrocil and continuing breastfeeding and MCT oil supplementation. All babies are on regular follow-up with normal lipid profile and growth and development also around the 25th centile and thriving well. From this presentation, learning point was when no secondary causes are really identified, genetic evaluation is better to diagnose the hypertriglyceridemia, which is a first tier test for the diagnosis. And acute management, IV insulin is safe and effective even in infants, but medical apheresis is safe and effective compared to exchange transfusion with less side effects. And long-term management with dietary modifications could be effective primary hypertriglyceridemia if we diagnosed and started treatment in early phases of infantile period. And pancreatitis treatment should be diagnosis and aggressive management is necessary to prevent the morbidity, which is the most common cause for morbidity and mortality in the hypertriglyceridemia. Thank you.
Thank you, Nishath. That was a very detailed presentation of yours. If there are, I saw one of the queries in the chat box by Dr. Vijay Gupta. He was asking about the mutation analysis. I'm sure that by now he would have been cleared from the last slide that you projected that there was a mutation analysis. Is it okay, Dr. Vijay? So I think this is all. This actually, can you go up to the summary slide of all the 4 cases, Nishath? Yeah, that's right. Had been for all the 4 cases that I wiser than the previous wisdom that we gone through. Every case was almost 40,000, literally very frightening. So we had at that point of time, we never tried any medical therapy. Literature was not in favor of medical using drugs in the neonates. So we could not do anything about that except going for exchange transfusion. Fortunately, the exchange transfusion brought the triglycerides down, and subsequent dietary modification with MCT and skimmed milk have helped the child to maintain the triglyceride below thousands. And the subsequent 2 cases, the LPL gene mutation, they were mild enough. So we were able to control them on dietary therapy itself, bringing down to a fairly lower level of triglycerides. The last case was also somewhere around 40,000. In this case, we were a little more wiser than the previous times. We went ahead and off late the review literature says we can go ahead and use some fibrates, try fibrates in newborns. So we have tried this gemfibrocil. Initially, we started at a high normal dose because the triglycerides were sitting somewhere around 40,000. We wanted to get that really down. We didn't want to have any pancreatitis. But then the baby developed a persistent vomiting. So we had to come down half the dose. Even with half the dose, the child is doing well. The triglycerides are kept below 1,000. We have not seen any pancreatitis in all these 4 children. They are thriving good. They are on a good follow-up with us. So with that knowledge and wisdom that we have shared today evening, we would like to take any other questions which are from the audience. Okay, so Aritra has asked, what are the organ dysfunctions of hypertriglyceridemia? Nishath, can you take that question?
Yeah, ma'am. Main organ is pancreas because lipolysis leads to release of free fatty acids, which is damage to the pancreatic cells, and this free fatty acids also stimulates the trypsinogen, which causes more damage to the pancreas. One more thing is heart, because compared to hypertriglyceridemia, hypercholesterolemia, because atherosclerosis is the one of the major complication with this one. So we have to one more is heart, one more is brain, for leads to strokes because of thick milky blood leads to strokes. Also some documentation is there. Obviously liver damage.
So fortunately, through our experience of these 4 years of managing such cases, I think keeping the triglycerides somewhere below 1000, it is really helpful. We are also yet to watch them grow up too. But fairly, as of our knowledge goes, getting the triglycerides below 1000, I think we can do away with pancreatitis. That is what my expectation is. Hopefully, the babies live up to that. A few other questions. Aritra wants to know if we could use IV lipids. I don't know in what connection you want IV lipids.
No,
can you be more?
For this baby, we didn't use any IV lipids. That baby came to us at 15 days of life. Before 2 weeks,
Yeah.
baby is uneventful period.
All these babies, none of them presented with actually the symptoms like abdominal pain, pancreatitis, etc. It was only a existent findings when they presented with for some other illness. Most of the 4 babies that we saw, none of them presented. They presented to hospital with a different reason. When we drew blood, we saw this blood was very lipemic. They couldn't be analyzed in the biochemical lab, and it was only the biochemist who informed us of the abnormality. So the clinician, we never suspected hypertriglyceridemia at the first shot. There's one more question saying whether we can use double-toned Arvin. Yes, for the first, the 2020, both the cases, the dietary modification, we had used only double skimmed Arvin milk for that, which the fat content is somewhere around, I think, 1.4 or something. Double-toned Arvin milk was what advised to the babies. We did not use breast milk for first 2-3 months till we got the triglyceride down, and then subsequently we advised the mother, but I don't think she lactated. The babies were doing well on Arvin milk itself. Of course, we are losing the benefits of breast milk, but this was how we managed the cases through. Any other doubts? Any other Elimeli madam and ma'am, can you add on if your experience in case Hyderabad has seen?
Yeah. Good evening, Dr. Anitha. As usual, your case series are very good, and your management is also so with evidence-based. And yeah, I had seen one case long back, and of course, the baby also had hyponatremia, which could be, I think that could be a false result as well. But the baby had chylocystitis as well. So this baby had lipidemic thing. So again, it was very difficult to manage. And then there was another case with lipodystrophy. So these were the 2 cases I had seen with lipemic plasma. But in a neonate, I think we haven't seen, and luckily, touch wood, till now we didn't find any difficult cases as well. So thank you, Dr. Anitha. Good presentations.
Actually, every case we moved on. We had to, the first case that we encountered, we were really confused. Triglycerides sitting at 43,000. We were very worried, when will we strike on pancreatitis for those children? So luckily, exchange transfusion was only our saving tool that we had at that point of time. For this baby, fortunately, we had fibrates coming in. So off late, maybe from the next on cases, we might use fibrates, and maybe as of now, literature, there is not much literature on fibrates in neonates, ma'am. So maybe future we can see this, try this, and maybe we can share it also.
Yeah.
And this is the first case that I've seen with lipemia retinalis, actually. Even though triglycerides above 4,000 is said to produce eruptive xanthomas, we couldn't see eruptive xanthomas in this newborn. But lipemia retinalis was very classic, unlike the other 3 cases that we encountered. That was only extra that we could learn out of these 4 cases.
Very interesting. Very interesting.
Thanks to the Zoom for which we could share and learn all this in different parts of the country. I'm really thankful to this e-learning. Otherwise, I don't know.
Questions are in chat box.
Yeah, please take it.
One is a presentation why in late 2nd and 3rd week. Actually, we also searched some articles. We also don't know why 2nd and 3rd week. Presentation is variable. not like related to triglyceride levels, and presentation is anywhere it is not given. We also searched and we noticed one China case which is presented in very early period, which is a day of life 5 only. After that, one case at day 11, and our case is very early period is around 15 days. There is no such reason is there behind that one. Ma'am, is it right, ma'am?
Yeah. Even I'm as ignorant as you, Nishath. Except for the literature review that we all did together, I have not much personal experience except for managing these 4 cases.
Yeah, ma'am. And a cutoff for hypertriglyceridemia, they are asking, ma'am. For newborns, it is not such cutoffs are there. We used NCEP articles, which is given for more than 1 year